Hello everyone. In today's session, we are going to discuss about severe acute respiratory syndrome. It is a continuation to the topic epidemiology of communicable diseases. The objectives to this session are the definition of Sars, incubation period, epidemiology, mode of transmission, pathophysiology of severe acute respiratory syndrome, clinical features, case definition, diagnostic test, complications, and lastly, the treatment of severe acute respiratory syndrome. Let us begin with the definition of SARS. SARS is a communicable viral disease. So we see that it is a viral disease and a communicable disease, hence categorized under the infectious diseases. It is caused by the new strain of coronavirus. Since it is a viral disease, it is caused by coronavirus. And this coronavirus is differing from the genetic structure from the previously recognized coronavirus. The new genetic strain of coronavirus, which is causing the SARS, is considerably varying in its genetic structure from the previously recognized coronavirus. Moving further to the most common symptoms in the patient who is progressing to SARS, they include fever, chills, malaise, myalgia, headache, dizziness, cough, sore throat, running nose. Is it clear? What are those? Fever, chills, headache, dizziness, running nose, cough, sore throat, myalgia, malaise. Clear? Fine. In some cases, there is a rapid deterioration. Few cases will have the rapid deterioration of the oxygen saturation. There is the low oxygen saturation found in these patients. They also show the acute respiratory distress. These patients require the ventilatory support. It is capable of causing death in many as 10% cases. So the coronavirus, which is causing the SARS, has the fatality rate of 10%. Chest X-ray findings will typically begin with a small unilateral patchy shadowing. So we have this small unilateral patchy shadowing on the chest X-ray, which is progressing in 1 to 2 days to become the bilateral and generalized. It is bilateral generalized shadowing along with the interstitial or confluent infiltration. So we see that the X-ray, it starts with a small patchy shadow which is progressing to the bilateral, interstitial or confluent infiltration. Adult respiratory distress syndrome has been observed in a number of patients, especially in the end stages. In the end stages, we observe the ARDS, that is acute respiratory distress syndrome in the patients. So here you can see the chest X-ray which is showing the patchy air shadowing. This patchy airspace shadowing is seen in both the lungs. Prominently you can find it in the mid and the lower zones. You can see the arrows here. In the mid and the lower zones we have the patchy airspace shadowing. Whereas here you can see that the chest X-ray is showing the bilateral infiltration. Mainly you can see it in the upper zones. The bilateral infiltration is seen in this chest X-ray. Moving further to the incubation period. The incubation period to the severe acute respiratory syndrome is estimated to be 2 to 7 days. On an average, it is 3 to 5 days. So what's the incubation period? Commonly, it takes up to 3 to 5 days. Moving further to the epidemiology. SARS coronavirus is identified as a causative factor of SARS. So we see the SARS coronavirus. SARS coronavirus is the cause of SARS, which is unusual atypical pneumonia that was first identified in the Gurgaon province in China in the late 2002. So we are discussing about the emergence of coronavirus. So the coronavirus first it was identified in the Gurgaon province in China in the late 2002, and the patient was identified as having unusual atypical pneumonia, not the usual pneumonia. They had unusual atypical pneumonia. Over the next 6 months, the virus started to spread to the different parts of the world, including the China, Hong Kong, Singapore, Taiwan, Toronto, and other locations in Canada. So from China, the Gurgaon in China 2002, it was first identified, and the patient present with an unusual atypical pneumonia, and then it started spreading to the various parts in the world, that is Singapore, Hong Kong, Taiwan, Canada, Toronto, etc. The infection has caused 8,000 illnesses and it has 774 deaths reported because of the coronavirus. The origin is stemming from yet to be identified animal reservoir. So we see that the origin it stems from an unidentified animal reservoir, perhaps to be believed to be the bats. It spread to the Himalayan civet cats and first infected the humans. So we see that the civet cats, first the Himalayan civet cats, they ate the fruits, they ingested the fruits and dropped them, which was picked up by the bats, and these bats spread the coronavirus to the humans. Is it clear? It is yet to be identified animal reservoir, that is the bats, which spread to the Himalayan civets and first infected the humans. And where was the first infected human found? He was found in the Gurgaon province of China in 2002. Unlike the other viruses of the respiratory group, SARS does not have a seasonal predilection. So we see that it is not having any seasonal predilection. As of early August 2003, about 8,422 cases were reported to the World Health Organization from all around 30 countries, with 916 fatalities reported. So the fatality rate has been increased. So we see that there were 8,000 cases and 774 deaths, and now the cases are 8,422 and 916 fatalities. The scientific consensus is that SARS coronavirus 2 is zoonotic in origin. However, source of original outbreak is yet to be determined. An intermediate host between the source and the introduction to human has been considered to be likely to very likely, and investigations are still ongoing. So we see that there is an intermediate host between the source and the human. So who is the intermediate host now? I told you the civet cats. I'll show the picture in the upcoming slide. And these civet cats ingested the fruit. So they are the original source of infection, and the intermediate host are the bats, and then they infected the human. So the original outbreak is yet to be determined. Intermediate host between the source and the introduction into the humans is considered to be likely to very likely, and still the investigation is ongoing. For the further information, see the reports from the World Health Organization convened global study of the origins of SARS coronavirus 2. If you're interested, you can have a further detailed study about it on your website. Then you can study the World Health Organization convened global study of the origins of SARS coronavirus 2. International flights have been associated with the transmission of SARS from symptomatic probable cases to passengers or crew. So the international flights, so the people who flew from Gurgaon of China brought the coronavirus to India, to Hong Kong, to Singapore, to Toronto, so many other places. So the transmission of SARS from the symptomatic probable cases, it was transmitted to the passengers or to the crew. World Health Organization recommends the exit screening and other measures so that we can reduce the opportunities for the further international spread. The international spread associated with the air travel during the epidemic period. So, the exit screening, if the person is traveling from one country and flying to the abroad to the other countries, we need to perform the exit screening of that individual to prevent the spread of the infection worldwide, especially during the epidemic period. On 31st of December 2019, World Health Organization was informed of a cluster of cases of pneumonia of unknown cause which was detected in Wuhan city, Hubei province in China. On 9th of January 2020, it was announced that the novel coronavirus has been identified in samples which were obtained from these cases. So, I told you in the earlier slides that there were unknown cases, unknown atypical cases of pneumonia which were reported in the Wuhan city, Hubei province in China. And when they checked the samples, it was identified that these cases had the virus genetic sequences of coronavirus. And we see that the novel coronavirus was identified in the samples which were obtained from these cases, and the initial analysis of the virus genetic sequences, it suggested that this was the cause of the outbreak. So what was the cause of the outbreak? It was the novel coronavirus. Let us just underline it. The novel coronavirus is the causative factor for the severe acute respiratory syndrome. On the February 2020, this new virus was formally named as Sars coronavirus 2. So we see that it was named as SARS coronavirus 2, and the diseases caused by it were named as COVID-19. Very popular pandemic, we all are well aware of it. It was caused by the SARS coronavirus 2, and the disease was caused by the name, it was named COVID-19. Moving further to the mode of transmission of SARS. The primary mode of transmission appears to be through direct or indirect contact of mucous membrane of eyes, nose, mouth with respiratory droplets or fomites. So we see that the direct contact or the indirect contact of the discharges from the mucous membrane of the eyes, nose, mouth with respiratory droplets or fomites. The use of aerosol generating procedures, the AGP, aerosol generating procedure. What is aerosol generating procedures? It is a medical procedure which is increasing the risk of spread of a contagious disease which is carried in an aerosol. So we see that the aerosol generating procedures which are increasing the risk of spreading of contagious diseases, they are the endotracheal intubations, bronchoscopy, nebulization treatments. In hospitals are amplifying the transmission of SARS coronavirus. So these procedures like the endotracheal intubation or the bronchoscopy and the nebulization procedures which are carried out in the hospitals, they are amplifying the transmission of the coronavirus. The virus is also shed in the stools, but the role of the fecal oral transmission is still unknown. The natural reservoir appears to be the horseshoe bat, which eats and drops the fruits which are ingested by the civets. They are earlier presumed reservoir and are likely amplifying host. So let us see the picture of the civet cats who are considered to be the reservoirs of the previous reservoirs, and they were considered to be the amplifiers of the infection. And then we have these horseshoe bats who are eating and dropping the fruits which were dropped by these civets. So these civets will first eat the fruits and then they drop them, and these bats will pick those fruits and eat them and infect the humans. H5N1 subtype of the influenza type A virus infection is also causing the severe acute respiratory syndrome. which is the human form of bird flu. We know the avian flu is caused by H5N1 when we discussed about the influenza, which you can find in the playlist of the Epidemiology of Communicable Diseases, or you can see the entire playlist of the SPM lectures which are uploaded. You can find in detail about the influenza, which I have explained in the previous sessions. So the H5N1 subtype of the influenza type A virus infection is causing the severe acute respiratory syndrome. It is a human form of bird flu or the avian influenza with having similar symptomatology. So the patient here presents with fever, malaise, myalgia, dizziness, headache, running nose. So the clinical features are similar to the influenza and the coronavirus. Other modes of transmission is including the fomites and through the hand contamination. Transmission may be amplified by the certain procedures like the endotracheal intubation, bronchoscopy, nebulization procedures, which are carried out in the hospitals. The transmission does not occur before the onset of symptoms or more than 10 days post resolution of fever. So now we are discussing about the transmission. When does the disease gets transmitted from one person to another? It does not occur before onset of symptoms. The transmission does not occur during the incubatory phase. It does not occur before the onset of symptoms or more than 10 days post resolution of fever. The SARS virus can survive for hours on common surfaces outside the human body and up to 4 days in the human waste. The virus can survive at least for 24 hours on a plastic surface at a room temperature and can live for extended periods in the cold. So we are seeing that how long the virus can survive. It can survive for 24 hours on a plastic surface. Just at the room temperature, the virus can survive on a plastic surface, and it can also live for the more extended periods in the cold temperature. You can also see the mode of transmission given in the picture, indirect or direct contact through the droplets, that is through coughing, sneezing, aerosol, and the saliva, and the mucus discharges from the oral cavity, nasal cavity, eyes, the mucous membrane, and there is viral aerosolization. The possible routes of transmission is through the whole blood serum. Fecal oral transmission is still unknown, through the urine, vertical transmission, and through breastfeeding. Contact with the contaminated surfaces or objects, or the contact with infected people who had no symptoms. Okay. Moving further to the pathophysiology of SARS. Entry of the SARS coronavirus inside the human body. Now we are going to discuss what's actually happening in the body of a person who is infected with SARS. First, the coronavirus enters into the human body and there is activation of the macrophages. So what are these macrophages? Macrophages are the phagocytic cells which play a key role in inflammation. They become activated and they release the inflammatory mediators. So we see that these macrophages, they are the phagocytic cells. As soon as the virus enters into the body, these macrophages play a key role. And they will trigger the receptors which are present on the macrophages by activating the various inflammatory cytokines. Okay, they will release the cytokines which will further activate the macrophages. And then there is activation of T cells, monocytes, and neutrophils. So we see that the monocytes here are also released from the bone marrow, where they will further differentiate into macrophages and they will release the pro-inflammatory factors. And then neutrophils are also the responders to the acute inflammation, and they are the most abundant leukocytes which are found at the site of inflammation. So once the coronavirus enters into the body, first into picture comes as the macrophages. There is activation of macrophages followed by the activation of T cells, monocytes, and neutrophils. Further, there is release of cytokines, that is interleukin 1, interleukin 2, interleukin 6, tumor necrosis factor alpha, and interferon gamma, which is resulting in a cytokine storm. So we see that these cells are they will detect and destroy the harmful organisms. And these inflammatory cytokines are released by the T cells. So we see that these T cells, what do the T cells do? The T cells, they will release the cytokines. They will distinguish from the self and non-self, and they will release the cytokines, and these cytokines will produce the cytokine storm. It is resulting in the cytokine storm. So what is the cytokine storm? The inflammation which is caused by the cytokine storm will disrupt the hemostasis of many organs. So this cytokine storm is disrupting the hemostasis of many organs, and because of the elevated levels of the pro-inflammatory cytokines, there is further tissue damage in the patient. You can see the inflammatory cascade is causing a damage. So there is pro-inflammatory cytokines which is damaging the cells through necrosis, through apoptosis. They will damage the cells, and they will cause the tissue damage, acute respiratory syndrome. Further, they will damage the many organs. They will disrupt the hemostasis, and they will cause the multi-organ dysfunction syndrome and sepsis. And lastly, the person ends up in the death. So sepsis, what is sepsis? Sepsis is when the body's inflammatory response to an infection is uncontrolled and it has started to spread throughout the body. Then this is happening here because the pro-inflammatory response is very excessive. Since the pro-inflammatory response is very excessive, it is causing the organ dysfunctions, collateral damages, and then multi-organ dysfunction syndrome, and the patient dies. Is it very clear now to you? What happens? The Sars enters, macrophages activated, then activation of T cells, and these cells, what do? First, macrophages will try to destroy the harmful organism. Not able to phagocyte, then they will present the antigen to the further T cells. T cells will get activated, and the macrophages are also releasing the cytokines, and they are activating the other cells. Altogether will release the cytokines. The cytokines, all the cytokines together forming the cytokine storm. Because of the excessive inflammatory response is continuing here, it is causing the injury to the many organs, tissue damage, severe acute respiratory syndrome, sepsis, multi-organ dysfunction syndrome, and lastly the patient experiences death. Is it clear? Now we see here the SARS coronavirus entering the body, causing the acute respiratory distress syndrome, tissue destruction, tissue damage, necrosis, hypoxemia, and it is causing pneumonia, which is presenting in the form of shortness of breath, cough, mucus production, and fever. And this cytokine storm, we can see first the macrophages activation, T cell activation, monocyte neutrophils, and then we have cytokine storm because of the release of inflammatory cytokines like interleukin 1, 2, 5, 6, interleukin 17A, 18, tumor necrosis factor alpha, beta, gamma, and interferon gamma. Is it clear? Moving further to the clinical features, the incubation period ranges from 2 to 7 days and may be as long as 10 days. So the incubation period starting from 2 to 7 days, on an average 3 to 5 days, at the longest it is 10 days. The symptoms are including fever, chills, malaise, myalgia, non-productive cough after a travel to the high-risk area. The elderly individuals or the immunosuppressed host may not have the classical features like fever, but these elderly individuals or the immunosuppressed host, like those who are suffering with HIV, they will present with acute confusional state or the diarrhea after the travel to the high risk areas. Because they are already immunosuppressed, they are going to present with confusional state or diarrhea after they have traveled to the high risk areas. The other clinical features, the respiratory tract manifestations, we have sinusitis, rhinitis, anosmia, that is loss of sensation of smell, and we have pharyngalgia, rhinorrhea. Oh, what is pharyngalgia here? Pharyngalgia is an unpleasant sensation, which is the physical discomfort like a pricking sensation or a throbbing, aching sensation, which is originating in the throat. And we have rhinorrhea, in the throat, sore throat or pharyngitis, inflammation of the pharynx is seen. In the mouth, we have ageusia. Ageusia is there is a complete loss of sense of taste. So there is anosmia, ageusia, rhinitis, rhinorrhea, and anosmia, sinusitis. In the lung, If there is pneumonia, acute respiratory distress syndrome, expectoration, cough with expectoration, dyspnea, chest pain. And then the patient also present with extra systemic symptoms. Let's first discuss the systemic symptoms. They are fever, chills, fatigue, malaise, myalgia. And extra respiratory symptoms include neurological symptoms like dizziness, headache, and impaired consciousness. And the muscular symptoms are myalgia, malaise, neck pain, back pain. The digestive symptoms is diarrhea, nausea, vomiting, and abdominal pain. Moving further to the case definition. The case definition is based upon the current understanding of the clinical features of SARS and available epidemiological data. So the case definition, it is based on two things. One, on the understanding of clinical features, and secondly, on the available epidemiological data. It may be revised as new information is accumulating. Case definitions can keep changing based upon the new information as it is accumulating. Case definition for notification of SARS under the International Health Regulation 2005. In the period following an outbreak of SARS, a notifiable case of SARS is defined as, from here the important thing starts. How do we define the SARS? In the period following an outbreak of SARS, a notifiable case of SARS is defined as an individual with lab confirmation. He is a person with a lab confirmation with SARS coronavirus who either fulfills the clinical case definition of SARS. He either fulfills the clinical case definition of SARS, or he has worked in a laboratory who is handling the live SARS coronavirus, or he is a lab technician who is working in the lab who is dealing with the live SARS coronavirus, or they are storing the clinical specimens infected with the SARS coronavirus. Is it clear? He is an individual who has lab confirmation that he has SARS coronavirus. And secondly, he might be a person who is working in a lab, who has worked in a laboratory, and this laboratory is handling the live coronavirus, or it is dealing with the stored specimens which are infected with the SARS coronavirus. Clinical case definition is a person who is having a history of fever, or he has documented fever, and one or more symptoms of lower respiratory tract illness, that is shortness of the breath, difficulty in breathing, cough. And thirdly, he is having the radiographic evidence of lung infiltrates. We have seen the x-rays showing the lung infiltration. They are consistent with pneumonia or acute respiratory distress syndrome, or autopsy findings which are consistent with the pathology of pneumonia or ARDS without an identifiable cause. So we see that either he'll have a history of fever or one or more symptoms of lower respiratory tract. What are the symptoms? You know very well, that is the cough, shortness of the breath, difficulty in breathing. And thirdly, radiographic evidence. Radiographic evidence, what does the radiographic evidence show? It will show the infiltrates which are present. They are consistently present in the lung, and there is patient is consistent with pneumonia or is having acute respiratory distress syndrome, or the autopsy finding is also showing the pathology of pneumonia or ARDS without identifiable cause. No alternative diagnosis fully explaining the illness. If he has no diagnosis which is explaining his illness, then we have to suspect it to be the SARS. The diagnostic tests which are required for the laboratory confirmation of SARS include the conventional reverse transcriptase PCR, RT-PCR test, okay, polymerase chain reaction, and real-time reverse transcriptase. So we see that we have RT-PCR test, that is real-time reverse transcriptase polymerase chain reaction. RT stands for real-time. PCR is RT-PCR, real-time reverse transcriptase. Polymerase chain reaction is PCR. It is one of the most used tests for the COVID-19. So the real-time reverse transcriptase polymerase chain reaction assay, which is detecting the viral RNA, is present in at least 2 different clinical specimens. That is, we see that it is present in nasopharyngeal specimen and stool specimen. or the same clinical specimen is collected on two or more occasions during the course of the illness, especially the sequential nasopharyngeal aspirates. Same specimen is found. You collected the specimen on two occasions or two or more occasions, but the same clinical specimen is found in the sequential nasopharyngeal aspirates taken, or a new extract from the original clinical sample tested positive by two different assays. So we see that a new extract is taken from the clinical sample which is tested positive by two different assays, or we are repeating the RT-PCR test or real-time RT-PCR on each occasion of testing, OR. Virus culture from any clinical specimen. So these are the diagnostic tests. Nothing but we are taking the samples, clinical specimens on two different occasions or two different clinical. One, we can take two different clinical specimens. Specimens could be nasopharyngeal specimen, or you can take the stool specimen. You see here, two different specimens are taken. Two different clinical specimens, nasopharyngeal or stool, or we are taking same clinical specimen but on two or more occasions, or a new extract is taken, and then we are repeating, or just you can see a repeat RT-PCR test is done, or the virus culture from any clinical specimen can be taken. The enzyme-linked immunosorbent assay, immunofluorescent assay. So we have ELISA, enzyme-linked immunosorbent assay, or we also have immunofluorescent assay, IFA, and the negative antibody test on serum which is collected during the acute phase of an illness, followed by positive antibody test on the convalescent phase simultaneously. So we see that during the convalescent phase, that is when the body is recovering from the illness, during that period the positive antibody test was found, and the negative antibody during the acute phase, when the patient was in the acute phase of an illness, the tests were negative, and during the convalescent phase when he was recovering, the tests were positive. Simultaneously the serum is tested, and a fourfold or greater rise in antibody titrate. So there is fourfold greater rise in the antibody titrates against the Sars during an acute phase of the serum specimen, and a convalescent phase serum specimen, that is the paired sera which is taken and it is tested simultaneously. Is it clear? So we are performing ELISA, or we are also performing IFA, where a negative antibody test on serum which is collected on acute phase of an illness and positive during the convalescent phase. And the second thing, there is a fourfold rise in the antibody titrate against SARS. One during the acute phase and convalescent phase. There is a paired sera which is tested simultaneously. The chest radiographs. The chest radiographs show the evidence of pneumonia in 60% to 100% of the cases. So up to 100% cases will show the evidence of pneumonia on chest X-ray in SARS. The radiological findings will include the peripheral lung involvement. There is peripheral lung involvement, focal air spaces, opacity, there is absence of cavitation, lymph adenopathy is seen, pleural effusion, you can see the pleural effusion, absence of cavitation, opacity, and focal airspace. High resolution CT scans are abnormal in 67% of the patients with a normal chest radiograph. So even if the chest X-ray turns out to be normal, when the high resolution CT scans are done, they turn out to be abnormal in 67% of the cases. Following abnormalities are seen in the laboratory test. What are the abnormalities which are noted in the laboratory test? Almost normal to low total lymphocyte count with lymphopenia. Lymphopenia in about half the cases, mostly due to the fall in CD4 plus T cells. So lymphopenia is nothing but the lymphocytopenia, where the blood has an abnormal low level of lymphocytes. lymphocytes, which are nothing but the white blood cells which play an important role in the immune system. So there is an abnormal low level of lymphocytes, mostly due to the fall in CD4 plus T cells. CD4 plus T cells are nothing but T lymphocytes, or helper T cells. That's because they are named so, because they help to fight the infection by triggering the immune system. So once there is a fall in CD4 plus T cells, they are not further triggering the lymphocytes. So consequently there is lymphopenia as well. We have thrombocytopenia, elevated liver enzymes like aminotransferases, creatine kinase, and lactase dehydrogenase, and the virus isolation is done by reverse transcriptase PCR polymerase chain reaction on respiratory sample, plasma, urine, or stool samples. Tissue culture and the detection of serum antibodies is done by ELISA, enzyme linked immunosorbent assay, or immunofluorescence test. Okay, is it clear? Fine. Let's move further. The COVID-19 diagnostic strategies. What are the strategies? We have molecular SARS coronavirus 2 genome and a serological test. We find antibodies against the SARS coronavirus 2 or structural SARS coronavirus 2 proteins or whole virus is seen. Now we see the X-ray findings. The X-rays are showing the faint, rounded, bilateral, peripheral, alveolar opacities. You can see the dotted arrows showing the faint. They are round, bilateral. Both the places you can see they are bilateral. They are peripheral, alveolar opacities. Next, we have the bilateral involvement. There is bilateral involvement and pleural effusion which is seen. It is a case of a 17-year-old male who presented with fever and a positive PCR for SARS coronavirus. On the chest radiography, we see that the patient present with a bilateral infiltration and pleural effusion. The conventional posterior-anterior chest projection. So this is a PA view. Bilateral opacities are seen especially in the lower fields. You can see the arrows here. The bilateral opacities are seen in the lower fields, and this opacities that could correspond to the dense breast tissues owing to the uncertainties around the right hemithorax arrows. So it's not very it can also owe to the breast tissues, but we can see that there is some uncertainty which is present in the right hemithorax. Moving further to the complications. As with any viral pneumonia, pulmonary decompensation is the most feared problem. So once the person contracts pneumonia, pulmonary decompensation is the most threatful thing which can come up. Acute respiratory distress syndrome occurs in 16% patients, and about 20 to 30% of the patients are requiring an intubation and mechanical ventilatory support. The sequelae of intensive care include infection with nosocomial pathogens, since the patients are admitted in the intensive care units for a longer period because of the parenteral nutrition, because of the intensive care procedures which are carried out. The patient can contract with the nosocomial pathogens, the infections which are occurring in the hospital. And then we have tension pneumothorax from the ventilation at a high peak pressures. When the ventilation is carried out at a high peak pressure, the patient can develop tension pneumothorax and non-cardiogenic pulmonary edema. Approximately 15% develop the severe disease which is requiring the oxygen support, and 5% of the patients had critical disease with complications like respiratory failure, ARDS, sepsis, septic shock. We have discussed all of this. So the SARS can result further in sepsis, septic shock, thromboembolism, multi-organ failure, ARDS, and it can also result in acute kidney injury and cardiac injury. Moving further to the treatment, non-pharmacological treatment includes the supportive care, respiratory support, nutrition support. Starting with the acute medical treatment, no specific medications are still available for the treatment of SARS. The use of corticosteroids in controversial high dose methylprednisolone 40 mg BID to 2 mg per kg per day, but it may be useful in patients with significant hypoxia and progressive pulmonary infiltrates on chest radiograph. So we are using corticosteroids. It is still controversial. We are not sure whether or not to use the corticosteroids, especially methylprednisolone is used, that is 40 mg methylprednisolone may be useful in the patient who are having hypoxia or they are having pulmonary infiltrates on chest x-ray. Preliminary studies have demonstrated the benefits of use of interferon alpha 1 plus corticosteroids in patients with SARS. Moving further to the prognosis. Is it clear? The last point. Preliminary studies have demonstrated use of interferon alpha 1 plus corticosteroids. Moving further to the prognosis. The overall mortality rate of identified cases is 14%. So we see that the mortality rate in identified cases is 14%. Mortality is age related. It is ranging from less than 1% who in patients who are aged 24 years of age, and it is more than 50% in people who are aged more than 65 years of age. So the age plays an important factor. The mortality rate is 50% in the people who are old age more than 65 years of age, and it is less than 1% in the people who are aged under 25 years. The poor prognostic factors are the advanced age, like we discussed earlier, the chronic hepatitis B infection. These people who are suffering with the chronic hepatitis B infection treated with lamivudine, high initiate or the high peak lactate dehydrogenase concentration. High neutrophil count on presentation, people suffering with diabetes mellitus, acute kidney injury, or the low counts of CD4 CD8 on presentation. Many subclinical cases they go undiagnosed. Seasonality, as with influenza, is still not established. Influenza is more commonly seen during the winter season, spring seasons, but the seasonality, the predilection to the season is not found in SARS. One third of the patients with SARS will recover from the illness. The remainder will suffer from the pulmonary infiltrates, which is causing tachypnea, shortness of the breath, and finally, they succumb to respiratory failure, multi organ failure, sepsis, and death. So, the pathophysiology is repeating again. It will lead to pulmonary infiltrates on chest x ray, and the patient will further progress into shortness of breath, respiratory failure, multi organ failure, MODS, and sepsis and death. Moving further to the vaccination. The first vaccine for COVID 19 was approved for use by the Medicines and Healthcare Products Regulatory Agency in the UK on 2nd December 2020. A further three have now been added to the list of approved vaccine of COVID-19 vaccination, and these three have shown to reduce the risk of infection. And these three new approved vaccines are reducing the risk of severe illnesses, hospitalization, and death. However, those who are fully vaccinated individuals, they also can still become infected with SARS coronavirus 2, and they can further transmit the infection to other people. The vaccine effectiveness data is continuously monitored, and it is important for surveillance and monitoring of SARS coronavirus 2 variants. So we see that the vaccine is continuously monitored, and it is important for the surveillance of SARS coronavirus 2 variants. Estimates of the vaccine effectiveness has changed over time and with the emergence of new variants of SARS coronavirus 2. So the vaccine effectiveness has changed as the new variants are emerging. The effectiveness has changed over time. Overall, these data have shown that 2 doses of vaccine is providing a level of protection against the symptomatic disease, hospitalization, and death. However, observed waning effect after 2 doses over time has necessitated the introduction of booster program for optimal protection. So the 2 doses are not enough. It has necessitated the introduction of a booster program so that we can get the optimal protection against the SARS coronavirus 2 and the further variants which are emerging. So we see that the vaccine effectiveness, why do we require it? So that we can keep monitoring the variants, we can have a surveillance of the SARS coronavirus 2 variants, and we see that the effectiveness has emerged, it has changed over time. The two doses of vaccine are just providing, to certain extent they are providing the effectiveness against the symptomatic diseases, but two doses are not enough. Now the introduction of booster program has been necessitated. Moving further to the differential diagnosis, we have atelectasis, bronchiectasis, bronchiolitis, bronchitis, COPD, Coxsackie-virus, cytomegalovirus, ecovirus infection, and emphysema. Let us have a brief discussion about the differential diagnosis. We have atelectasis. The clinical manifestations which is seen in atelectasis is dyspnea, orthopnea, tachypnea, pleuritic chest pain. We see that patient presents with pleuritic chest pain, tachycardia, cough, dry or a productive cough, and fever if the infection is superimposed. Is it clear? Atelectasis. We have studied about the atelectasis, and then we will move further to the bronchiolitis, the lower respiratory tract infection which is affecting especially the babies and young children. Common symptoms in bronchiolitis is rapid or noisy breathing, shortness of the breath, vomiting after feeding. So the patient presents with noisy breathing, vomiting, shortness of breath, irritation, nasal flaring, and whooping cough. Then we see the difference between bronchitis and pneumonia. Bronchitis is inflammation of the bronchus, and pneumonia we have discussed in detail. Now let's see. The bronchitis, the patient presents with fever and chills, severe coughing. The cough can produce greenish expectorate, yellow mucus expectorate, sore throat, wheezing, tightness in the chest, feeling of fullness in the abdomen. Whereas in pneumonia, the patient presents with fever, fatigue, confusion, chills, sore throat. Again, the coughing, the severe coughing will be there, yellow, green, and bloody mucus production, shortness of the breath, chest pain, nausea, vomiting, loss of appetite, muscle pain. Then comes bronchiectasis. In bronchiectasis, there is cough with sputum production. So the patient presents with cough and sputum production. We have the sputum to be thick and tenacious. Okay, yeah. So we see we are discussing about the bronchiectasis. Cough will be with the sputum production which is thick and tenacious. Hemoptysis can result from the airway neovascularization and rupture. The digital clubbing is seen in the lungs. There is crackles, rhonchi, wheeze, and the exacerbations which will worsen the symptoms for more than 2 days will require the treatment changes, and they will cause the further bronchial damages. And the dry bronchiectasis is associated with non-tuberculous mycobacterial infection, and the sputum production is comparatively less here. Just that you have to remember the names for the differential diagnosis: atelectasis, and we have bronchitis, pneumonia, bronchiolitis, bronchiectasis, and lastly we have COPD. So we know bronchiolitis. What is bronchiolitis? It is inflammation of the bronchioles which is caused by the viral illnesses. Okay. Pneumonia, what happens? There is accumulation of fluid or pus in the parenchyma. And then we have bronchitis, inflammation of the bronchus, and atelectasis where there is a collapse of the lung. And then we have COPD, chronic obstructive pulmonary disease. In chronic obstructive pulmonary disease, the patient will present with cough, then production of mucus, fatigue, shortness of the breath, dyspnea, chest discomfort. You can see the healthy airway here. Here the patient is having obstruction. There is mucus production, there is obstruction, chronic obstructive pulmonary disease. So moving further to the prevention, As there is no vaccine against the SARS, the preventive measures for the SARS are control, are detection and protective measures. So we know that the vaccine is not available. Since the vaccine is not available, the preventive measure is appropriate detection of the cases and carrying out the protective measures, which include the identification of a person who is suffering with SARS, their movement in the society and their contacts, the people who with whom they are in contact with, the effective isolation of SARS patient in hospitals, and the appropriate protection of the medical staff who is treating these patients. The comprehensive identification and also the isolation of the suspected SARS cases. So, just for instance, if a person is infected with SARS, we need to see his contacts. And his contacts, the comprehensive identification have to be done of those people, and they have to be isolated of suspected SARS cases. The simple hygiene measures including the hand washing after touching the patients, or use of the appropriate and well fitted mask, or introduction of infection control measures. So what are the basic hygiene measures? Hand washing and using mask, introducing the infection control measures. And also we discussed earlier the exit screening of the international travelers, the timely and accurate reporting and sharing of information with other authorities and governments. So we need to report the cases to the authorities. Timely and accurate reporting have to be done, and we need to share the information with the authorities and the government. Thank you. With this, we come to an end of the session. Severe acute respiratory syndrome. I hope it is clear. If you have any doubts, put them down in the comment section. And if you like the video, hit the like button and subscribe.